Hello everybody, welcome to another of the BIR webinars. It seems a little strange sitting here talking to my computer, but hopefully people can hear me and we can interact as we go on through this. It's a huge topic to cover in 45 minutes, so I'm going to concentrate on various aspects of it and on particularly on the central nervous system when we actually get onto the clinical part, so that we can maybe add another BIR webinar in the future and maybe get some feedback from everybody as to what else they'd like to hear. I thought we'd start with a poll, so I've got a bit of an idea what the audience out there is. So if we could have the first poll question up for people to interact with, please, that'd be great. So basically, this is just for me to get an idea of the audience I'm talking to. Do you currently do fetal MRI? Are you performing a clinical service? Okay, so the answer is most of you no, which is good because quite a few of my slides are starting off from the basics, but I can see that some of you are actually doing fetal MRI. Welcome to the people the other side of the world too. I noticed somebody's just in from Australia. And if we could have question 2, please. Would you like to do fetal MRI? Would you like to get involved in this service? So it seems the majority of you would like to do it. And the rest, I assume, are just interested or want to know for clinical reasons or want to use the service rather than offer it. So we move on to the sort of slide preparations with the questions then. Okay. So ultrasound is probably what we all know is fetal imaging. It's widely available. It's almost in every hospital now, even the small DGHs and cottage hospitals. And there's a large number of years of experience with it. There are specialist centres, and the technology is evolving all the time. I think this is an important aspect because fetal MRI has been around now for several years, and as we've improved with fetal MRI, our ultrasound has actually improved as well. So the original data of what we were comparing and how much better MR was is probably not accurate for today's data. But ultrasound does have its limitations, and those doing it will know that there are limitations with the increasing size of the population, that a lot of our pregnant women are now significantly overweight, and that layer of fat tissue to go through the ultrasound to go through is making it very difficult. Some of the patients won't allow us to do transvaginal ultrasound, and we're having difficulty getting to assess the fetus. In other cases, the abnormalities occurred later, and the ultrasound is technically challenging because the fetal skull is ossified and the sound waves can't get through. So there's lots of areas where MRI is useful to ultrasound, but ultrasound is going to be the mainstay of obstetric imaging and is going to be the gatekeepers to who comes to MRI. Limitations, as I said, there's limitations of experience. If you've got some really good ultrasonographers, then you get some really good images. The equipment, we'd all ideally like the most up-to-date piece of technology we've got, but in realistic terms, we're left with the equipment we have available, some of which is quite old and some of which is restricted. I've already mentioned the patient's body habitus, and we have got an increasing obesity population throughout the Western world, and the lie of the fetus can cause problems. The other issue is the amniotic fluid. There can be too much, so the baby's all over the place, or there can be too little, and you've actually not got the acoustic window you need to actually see the fetus clearly. So lots of problems with ultrasound, but similarly the same with MR. So what can we do with MRI? We've got increasing experience. There are more and more centres setting up, and the centres that have been doing it for several years have now got quite a lot of experience behind them and are able to help out and teach other centres. So internationally, there's a group of us that are trying to set up and get other centres in our own countries up and running to provide a clinical service by providing a backup reporting service, second opinions, going down and helping them set up the sequences. But there's still limited availability, particularly in the UK, and there's limited trained interpreters. The issue here seems to be that the obstetricians would like somebody who could interpret perfectly already, just produced from out of thin air, and we haven't got people trained up because there aren't the training schemes and there aren't the jobs available. The other problem with MRI is the cost of it, the cost of the machine, the demands on the machine, the time constraints, because everybody wants MRI for all the different specialties. But it's an improving technology, so the scan time is getting shorter, we're able to do more, we're able to look at more of the fetus. So it's going to be an evolving technology that remains important. And there are certain ultrasound abnormalities that can divide more accurately and detect, and it should be seen as an adjunct to ultrasound rather than a replacement. So how do we do it? I think for the fetal brain, we should do T2 single shot fast spin echoes. That's the workhorse of fetal MRI. That gives us our anatomical definition. And if you can get that in 3 orthogonal planes of the baby, that's great. And then a T1 axially and a DWI axially. And those 3 sequences are enough for a diagnostic scan. So get good quality images, a great diagnostic scan. If we do the fetal body, I would do the same T2 workhorse in 3 planes, a T1 sagittally this time, and a DWI through the kidneys, because it actually picks up renal function. So you don't need lots of complicated scans, you don't need lots of additional sequences, and those that are being done in research centres are still being evaluated. So with this sort of sequence, you can get the patient on and off the table within a 30-minute time slot, as long as your radiographers are getting the experience. They need to be quick and the baby settles and doesn't move all over the place. So 1.5T versus 3T, we were recently removed from our restriction. Until 2 years ago, we couldn't do anything other than 1.5T in the UK, whereas in Europe they could use 3 Tesla scanners. We've recently had changes and we can now use up to 4 Tesla. We've limited experience at 3 Tesla in the UK. The Europeans have more. I'm not sure that anybody really knows if there's a diagnostic difference. It's been done for availability in the past. And do we know if 1.5 is better or 3? I don't think that data is available. So clinically, you do what you have available. If you've got a 1.5, there's more experience on that, so I would stick to that. Fetal MRI, it helps if the mum's relaxed. It helps if you explain the procedure to them. I put all my patients into the scanner feet first. I don't see any point in putting them head first and putting them all the way through the scanner. Put them feet first in a comfortable position. If the partner can go in the room with them, that's great, because it tends to make them more relaxed, and we find that most of the partners are willing to go in, and they can stand as close to the patient as they like, hold the hand, chat to them. The French groups think that restricting the food of the mum will keep the baby stiller. The Americans give juice and cookies 30 minutes beforehand, and that they think that keeps the baby stiller, because the baby's tired after it's been fed. We give the patients music if they want it, or access to the radio through the headphones. So basically, you're trying to get your mum as relaxed as possible for the procedure, so that if she relaxes, hopefully the baby will relax as well. So I say patient position, feet first into the scanner bore, and then really depends on your scanner type, whether you want them supine, lateral decubitus, semi-lateral decubitus. Basically, a comfortable position for the mum where you can get the coil you need across the mum's abdomen, and that isn't too bulky, and then you can just progress with the scan. You've no idea what position the baby's in, so it really doesn't matter what position mum's in. This is just show you, this is the Siemens that we're using currently, and the coils are a little bit bulky. So we find that this actually goes on much easier if the patient is supine. If the patient can't lie supine, we put them in a semi-lateral decubitus. The 3T has this raised perspex cage which goes over the abdomen and takes the weight of the coil. So again, that's designed for supine. You can remove the perspex cage and just put the coil on them if you want them in a slightly different position. So it's adapting to what scanner you have and what the patient's needs are. This is the Philips 1.5, and you can see the patient's in a lateral decubitus here, and it's very easy to get this coil across the front of the patient. So you just have to have a go, find out what's best for you, what's best for your scanner, what fits your patient's best. Coil choices, I tend to use the body coil because that gives me good coverage without having to move the coil around. The cardiac coil is also useful, but then you have to find the area of the fetus you're looking for and maybe readjust your coil, and that increases your scan time. If you're moving multi-receive coils, your signal data is not uniform, and sometimes you still have to move the patient around to get the best bit of information for the bit you're interested in. Again, it's just trial and error. So sequences, we use the T2 single shot fast spin echo, as I said, but we've developed this from existing ones. So we go through the scanner's existing protocols and choose the nearest one, knowing that that's suitable for that scanner, and then adapt it for what we need. And our aim is to increase the speed without excess decrease in signal. And it'd be great if quality, resolution and speed could all be improved, but whenever we improve two, we lose the other. So the first few cases you do, you end up tweaking your parameters a little bit. If you've got an MR physicist who can come and join you, that's great, because it really does speed up the process, and they've got lots of other ideas of how to improve your images. And then the time we're taking depends on the amount of data. So if you've got a very fidgety fetus that isn't settling, you can reduce your number of acquisitions to 1, keep your scan time really short, or do scans in little blocks so that you can keep it as short as possible. What we do find is that if you continually do a T2 scan, the fetus seems to get used to the noise and will settle. So you may do 3 or 4 scans before you get one good quality image, but after that, the quality of your images improves. However, when you move on to your T1, the noise changes, the fetus appears to wake up and it moves. I always do my DWI at the end because that's the noisiest scan. It certainly wakes most of the babies up. It also shakes the table a little bit, and mum is very aware of the vibrations. So that's literally my last scan. And if the baby's really moody, sometimes we don't even do that. So our major problems are movement. We've got some predictable movement, which will be the heartbeat in the fetus, but most of the movement is completely unpredictable. So all the built-in scanner manufacturers systems they use, so things like Propeller, are for predictable movement, and they're not particularly useful for fetal MRI. As I said, the baby gets used to the T2 noise, so if you just keep repeating your sequences, eventually the baby will settle. If you can decrease the time taken to do any of your imaging, it will improve the quality of your images. So you can try things like reducing your matrix size, decreasing your field of view, changing the shape of your field of view, anything to get that scan time quicker to get a better quality image. So this is the standard T2 that none of us would try using on a fetus. This is an axial section through the brain. And then this is the single shot fast spin echo, which is the workhorse of fetal MRI. And this is sagittal section, so fetal brain, nose, lips, chin. And you can see the improved quality of the image. Oh, sorry. So this is the single shot fast spin echo, and there's some parameters that people can look up, copy down. They're just the advised parameters. They'll depend on which scanner you use, which manufacturer. It sometimes depends on the patient. And you're after as much data as you can from each slice to get an image where you can recognise the fetus. So head, spine, down to body. And this gives us really good detail of fetal anatomy. I use a high T2 if I'm looking at fluid containing lesions, so cysts, fluid in the lungs, cysts in the abdomen, cysts in the brain, as it gives a better quality of the edge definition, but it isn't an essential sequence. The T1 is useful for picking up hemorrhage in the brain. It's also useful for meconium, as you can see here, and the liver. So it's got quite a lot of uses. The overall value of it for any anatomical detail is poor, but you're looking for it mainly for hemorrhage. One thing to be aware of is the fetal fat doesn't show up the same as adult fat until late 3rd trimester. So if we're looking for lipomas or anything with a fatty definition in it, you won't see it on the T1 as you would do in a child or an adult. The balance gradient echo is quite good for giving you edge enhancement. So if you want definition of edges or define margins between different tissue structures, but you lose the inherent definition of the individual tissue. So you lose your definition of the brain parenchyma when you use this sequence, but you get a very good definition of outline. So it's useful if you're looking for heterotopias, cortical heterotopias, ventricular margins, if there's been any infarction. or any bleeds. So it's good to add to the sequences. And the DWI of the brain, I use a B-value of 600 to 800, depending on the gestational age. And the easiest way to do it clinically is just put the 2 B-values in for every DWI you do, then you don't have to manually select it. I'm looking for this for things like infarctions, areas of calcification will show up on the DWI. If you do it on every patient, you get used to seeing what it's like for normal, you get used to seeing the changes with normal gestational age changes, and then when you see a pathology, it's more evident. But it's really useful for babies that have had infarcts particularly. So say sequences I'd use the T2, single shot fast spin echo, repeat that until we've got the images we need, a T1 weighted sequence and a DWI. Other people are using more advanced sequences, and I think they sit to stay in the research arena at the moment. So these are sort of image quality we're expecting to get. So this end image is your standard T2. You can see with the balanced gradient echo, you've got more definition between the margins of tissues, but less inherent definition, and the same with the stir sequence. So to optimize your image, if you can shim to the patient rather than use the presets, that's great. That does increase the time that the radiographers spend setting up their images. And it gives time for the fetus to move. So it's the sort of thing you start to do as you get used to scanning the fetus, and you can want to increase your image quality. If the fetus is moving, we can reduce the slices. Make sure mum's comfortable, make sure she's not needing the toilet, make sure she's not feeling sick. Some of our patients won't tell us. The more comfortable the patient is, the less the fetus moves. So before we move on to looking at different pathologies, I thought we'd do another poll question. So given that now a lot of you are not doing fetal MR, be careful with this one. Which of the following indications do you think we should do? Mild ventriculomegaly, moderate ventricular. Is the question showing up clearly? Because it's not at my end. Yeah, you've got it at your end. Okay, so if you could just, oh yeah, mild ventricular, severe ventriculomegaly. Which of them do you think would be good indications? So there's some interesting results there, and as I go through the next section, you'll start to understand where I'm coming from with why we do it. I'm particularly interested in the response from mild ventriculomegaly and severe ventriculomegaly, in that clinically I tend to use my fetal MRI to change the clinical practice and the management of the patient rather than to make a definitive diagnosis. But as we talk in the next section, the different opinions will come through on that. So MRI is particularly good for parenchymal abnormalities, things that ultrasound struggles with, looking at neuronal migration, looking at cortical malformations, migrational abnormalities, irregular ventricular walls. Ultrasound can see some of the walls clearly, but not both walls, not all the ventricular walls as clearly as we'd like to, and may miss heterotopias. It's also useful when the skull is ossified, because the ultrasound waves can't penetrate through and you get such a big acoustic shadow, you're not seeing the brain detail. Obesity is less of a problem for us, but it is still a problem and it still reduces our image quality. And these are the sort of difficulties we have when we're starting fetal MR. This is a 22-week fetus with just the start of the sylvian fissure, very smooth brain otherwise, and by 40 weeks we've got lots of cortical and gyral pattern forming, and what we typically expect to see in a neonatal brain. The 22 weeks to 40 weeks appears to occur in a set pattern, and when I started fetal MRI, the only information we had was from pathology cases where the brains had been fixed and shrunk and dried and were much more clearer in their sulcal and gyral pattern. What we have now is books by the French group. Catherine Garel has produced a lot of books with images at each gestational age, so what we expect to see. As I said, the cortical and gyral pattern develops in a specified manner, and if that is abnormal, it indicates pathology. So these bench books are great, so we can pick up abnormalities, and they also help us to see how far the delay is in each baby, and is this something we would be concerned about, or is this within normal limits? So these bench books are really good, and once you start doing quite a lot of fetal MRI, you actually get your own eye in and you can recognise certain different gestational ages more easily. So this is what we look like at different gestational age. So the 22 weeks, a very smooth skull, a very smooth brain surface. We've just got the start of the Sylvian fissure here. It's starting to look square. 28 weeks, we're starting to get more of the sulci forming. And then at 32 weeks, the Sylvian fissure is much more closed off. The edges have met, so a percolization has happened. And we haven't got a neuronal migration pattern. If you look back at the 22 weeks, we can see bands of different shades of grey as the neurons migrate from this dark ganglionic eminence out to the cortical margin. And we lose that about 26, 27 weeks, and then certainly by 32, far more folds, but less of the differentiation here. Vermian growth is also interesting because the posterior fossa is delayed compared to the supratentorial structures. So at 20 weeks, you've got a very small vermis, quite a lot of CSF in the posterior fossa. It's very easy to get an abnormal angle on ultrasound and make this pathological. 26 weeks, we've got a bit of catch-up, but still got quite a prominent amount of CSF space. And by 32 weeks, it's almost as if the posterior fossa is caught up. There's a similar amount of CSF space as we've got supratentorially. We've got a much more defined cerebellar vermis. So it's important to either have the bench books to refer to or have some knowledge of normal development at different gestational age if you're going to try and detect the pathology. When we first started, we looked at it and compared our charts to ultrasound, and for the majority of the measurements we did, the ultrasound and the MR coincided. So this is the MRI, which coincides nicely with the 3 different published ultrasound measurements. However, when we looked at the cerebellar vermis height or at its AP diameter, this was our MR, and these were the published ultrasound. And despite the fact that we were absolutely convinced we were measuring in the same plane and measuring the same things, we've got this continual discrepancy. This isn't a problem as long as you compare MR with MRI. So if you do MR measurements, you're not to compare them with the ultrasound measurements. And again, we've been saved by the French group who've published all their MRI measurements and given us a nice basic normal data to compare to. And that's available both as papers or as a book. So why would we do MRI? Abnormal ultrasound, an inconclusive ultrasound, additional abnormalities, would it affect management, alter prognosis, inform the delivery, inform the parents of what they've got to deal with, or inform postnatal surgery? And occasionally, if there's a family history, we want to exclude abnormalities. So what for? If we look at the central nervous system, supratentorially, we're looking for congenital or structural abnormalities, ventriculomegaly, infection, infarction, tumours. Infratentorial, we're often looking at the development of the cerebellum, but also at vascular structures. So if we look at ventriculomegaly, if you look at the literature, the incidence is quite low, but it's important, and we'll flick over this to the MR side of it. The prognosis depends on the degree of ventriculomegaly and the associated abnormalities. Is it unilateral or bilateral? What's the gestational age when we're scanning this, and does it progress or regress, or is it stable? So in 20-week scan, you're often isolated and it's usually mild. If we look at the mild ventriculomegaly, MRI is picking up additional abnormalities in 6 to 8% of patients, and that actually alters their prognosis and their management. We've not found any value in following up these patients after their first MRI scan. We've not found anything developing later on in gestation. And it's a similar response as we've seen in postnatal studies, that there are these additional abnormalities that weren't detected on ultrasound. Late in pregnancy, the ventriculomegaly is often severe. There's more additional abnormalities, but because the ventriculomegaly is severe in the first place, the actual prognosis doesn't alter. So these patients are given a poor prognosis. They can choose to interrupt the pregnancy if they want. The additional abnormalities doesn't change that management plan. It may change what parents think, but doesn't change the management plan. And the numbers we see are very small. So is this really of economic value, or would we rather do the mild ventriculomegaly where we pick up less, but we make a difference to management? And these are just the sort of things we're looking at. This is an open spinal defect. So this is the skull, the dark line. There's no extraaxial CSF space, so there's no white fluid below it. We're straight down to parenchyma, and we've got very angulated ventricles. They're quite pointy and quite squared off margins. The only thing we see that in, other than an open spinal defect, is a baby that's actually died in utero. And this is the spinal defect. You can see the skin and the muscle as the black line coming down, and then suddenly it stops, and we're left with a thin membrane over a significantly large spinal defect. This was one of our early cases where it was referred as isolated hydrocephalus. You can see the dilated ventricles, but the cerebellum is also very small, even allowing for gestational age, and we've got a gap here. This is the postnatal follow-up. So this wasn't isolated. It did change the prognosis, but the parents continued with the pregnancy. Intraventricular bleed. This is your axial section. The blood is dark on your T2. It's bright on your T1, and the brightest areas are the freshest bleed, and the darker areas are the older bleed. And this has caused significant destruction of the brain on this side. All this area is edematous brain parenchyma that eventually will just be replaced by holes. So significant prognostic outcome. Heterotopia, here's the initial MRI. So normal extraaxial CSF space, slightly enlarged ventricles, little black dots of heterotopia. These aren't quite normal. Follow-up scan as the patient was continuing pregnancy, and the little heterotopic nodules can be seen all around the ventricular margins, and that was confirmed post-delivery. The post-delivery scan again shows these little nodules. This was one sent as periventricular leukomalacia. We've got cysts around the ventricles, which gave the appearance of ventriculomegaly, particularly anteriorly, yet we haven't got any parenchymal destruction, and these appear to be ventricular cysts rather than periventricular cysts. And this pregnancy was 36 weeks at the time. She was going to continue, and this baby's actually done exceptionally well. So it isn't a true PVL in that it's not destroyed parenchyma, but we've certainly got cysts there that are causing expansion of the ventricles. Say the prognosis depends on the degree of ventriculomegaly. So most isolated mild, 100% alive, very little morbidity, if any. Moderate, and you're looking at 25% having some degree of morbidity, and severe, only 7.7% are alive, and they all have some degree of mortality and mortality. So 7.7% are alive, and they got morbidity associated with it. So severe ventriculomegaly has a poor prognostic outcome. If we find additional factors, it doesn't change management plan, whereas mild ventriculomegaly has a good prognostic outcome if it's isolated, but additional findings will change management plan. So locally, we're doing mostly mild ventriculomegaly and not doing the severe ventriculomegaly unless the parents really want it. This is a severe ventriculomegaly. This is the ultrasound scan, very little parenchyma around the outside. MRI shows the significant reduction in parenchyma, disappeared completely at the back, and this is just due to the increased CSF within the ventricles. It's actually just stretched the parenchyma, so it's effectively popped, and we're left with this cystic malformation. No, the interventricular septum is there in the higher parts, the falx is present, and there probably was a Cavum septum pellucidum. But if you get severe ventriculomegaly, this is often disrupted. The other cause of severe increase in fluid is holoprosencephaly. So if you go back to this one, that's your ultrasound appearance, fluid-filled area with very little parenchyma. Very similar for the holoprosencephaly, fluid-filled lesion, very little parenchyma. But this is holoprosencephaly, so a single ventricle that's formed, no attempt at cleavage, thalami are fused, and a thin rim of parenchyma around the outside. A very poor prognostic outcome here, and most of these patients would choose to terminate. There's lots of other associated features we can see. So again, another case of holoprosencephaly, the single ventricle that's formed, so single amount of CSF space, thin rim of parenchyma around it, and you can see how little parenchyma is at the back. It's all anteriorly, and thalami fused. Alternatively, there's hydranencephaly. This time we've got a midline falx we can see. We've got a little rim of brain tissue. We've got frontal lobe and occipital lobe on the sagittal views, and we've got a thin membrane here. And this isn't severe ventriculomegaly. This is thought to be due to infarction early in development, and this is actually just the meninges. There's no real parenchyma left, and again, a very poor prognostic outcome. Hemimegalencephaly often comes through as a unilateral isolated ventriculomegaly. Here you can see the very large ventricle on this side, and it's difficult on ultrasound to actually determine, is this side normal apart from the large ventricle and this abnormal, or is this the normal and this the abnormal area? So this is the normal side, which has been squashed by this overgrown opposite side. So it's a large amount of parenchyma. It's not well formed. It has migration abnormalities as well, and it has a poor prognosis. But this is hemimegalencephaly, and this is your normal half of the brain. Hemorrhages will show up on the T2. They show up as little areas of dark signal. So this is hemorrhage within the ventricle, and this is a baby with ventriculomegaly secondary to a spina bifida. So no extraaxial CSF space. So we've got the black line of the skull against the parenchyma, and then the white of the CSF. And on the sagittal image of the baby, you can see the very significant defect in the back, in the whole of the lumbar and sacral region. This is the same slide as you've seen before. So again, angular morphology to the ventricles, no extraaxial CSF space, and the open defect. This baby was unilateral ventriculomegaly, and when you see this side, you can see that it's definitely bigger than the other side. The parenchyma around it appears normal. It appears just a little bit thinner, but not much. But there's a cyst there. There's a membrane that's just visible. And again, a membrane. Thank you. So we've got this membrane that's just visible, and again, a visible membrane here. And this is the dilated ventricle behind, and this is a cyst that's causing local obstruction. And we just watch this cyst, and it gradually resolved over time. This is a baby that's had an infarction. So we've got an area of destroyed parenchyma. So you can see this isn't symmetrical. And the margins here are irregular and abnormal. If you follow the parenchymal margin around, it's a nice pencil black line, and then it becomes an irregular one and it disappears. And then we pick up the cortical margin again. So this is a recent event with disruption of the cortical margin, most likely to be an infarct, and we've got parenchymal destruction. If you look at this one, we've got a similar picture, but we've got a thicker parenchyma here. We've got an irregular outline that's intact, so this has happened early on in gestation because we've not got destruction. And we've got this very difference. We've got significant difference between the two halves. We have got a bit of ventriculomegaly on one side, but this side is completely underdeveloped. And this is a similar case, underdeveloped side, so irregular, abnormal, no normal neuronal migration patterns, so no bands of grey as we've got on this side, and just a thick degree of parenchyma here. So this is an underdeveloped area that hasn't, underdeveloped hemisphere that's happened early on and is not going to develop further. So this again has a poor prognostic outcome. Sometimes we get these areas where we've got increased fluid, but when you actually do the imaging slice by slice, you don't appear to have any disruption of the brain tissue. It appears to be displaced rather than disrupted. And this is this baby again. We've got this increase in CSF space here and a cyst, but it's pushing the parenchyma. It's not destroying it. And when we followed these cases up, they tend to have a good outcome. However, this baby had some asymmetry. This is a parasagittal section on one side, and this is it on the other. So not only has this baby got a interhemispheric cyst that's displacing the parenchyma, but it's got some abnormal parenchymal abnormalities. The parents continued, and this baby was born with a small area of parenchymal abnormality, but at the moment is developing normally. The other area we're asked to look at a lot is the corpus callosum. And this is a sagittal section. This is the normal corpus callosum. It's seen as a dark black band from the midline. You see all the anterior cross, arching across right the way back to the back part. If it's absent, your sulci and the fluid within them come right the way down, right to the middle of the brain. So you haven't got the dark band of the corpus callosum. However, you can see that better on the coronal sections with MR, and as you can see on this one, the tissue comes down and turns back in. So we haven't got the corpus callosum, which should connect across. We can't see it on the axial sections. We should see it at the front and at the back. And what we have is a typical colpocephaly, or a teardrop shape to the ventricles. And interestingly, these will increase in size, but here the size doesn't appear to relate to the prognosis. So you can have severe colpocephaly with agenesis of the corpus callosum without the detrimental effects we see with severe ventriculomegaly. There's another case where you can see easily on the coronal section there's nothing connecting the two halves, and if you go slice by slice you will not see the corpus callosum, and it's probably the easiest orientation to look for this on. This baby also has some cortical malformation. This is one parasagittal slice and you can see the irregularity, and the other parasagittal slice is normal for gestational age, so it's nice and smooth. Again, this family continued and the baby's doing quite well, but it's only 6 months old. There's further examples, no connecting band, so no corpus callosum there, but you can follow the margins round and it just curls back on itself. You can see on the sagittal section how the fluid filling the sulci comes right the way down the midline. It's not stopped by a band of tissue. And again, this baby had associated cortical abnormalities. The ultrasound could easily pick up this agenesis of the corpus callosum. What it couldn't see and what it didn't see were these abnormalities. And even with retrospect, when the patient went for a follow-up ultrasound, it was really difficult for them to pick up the parenchymal abnormality. So when the patient continues, we will do repeat MRs, usually around 32 to 34 weeks, just as a single repeat, to see how bad the cortical malformation is. So we do most of our follow-up with ultrasound, but we will do a repeat MR later in gestation. Cavum septum pellucidum can often be absent and the corpus callosum present, and it can often be associated with other abnormalities. Sometimes we don't see those until late second or third trimester, and sometimes not even till after birth. So if the cavum septum pellucidum is absent, we need to counsel for a possible associated abnormalities, and that's left really to the obstetric colleagues. We just need to pick up anything that we see at the time. This is just back, having shown you lots of abnormal, another repeat normal scan to get you orientated again. And as you can see on these coronal sections, the corpus callosum is clearly seen on each section, branching across. And if you look carefully on this scan, there are two little black lines. I'll move the arrow so you can see those two little black lines. And they're the leaflets that form the cavum septum pellucidum. So they should be visible on the coronal section as well. So here's a baby with a possibly absent septum pellucidum. There's a suggestion of a black line there, but it doesn't look quite normal. There's a suggestion of a nice septum pellucidum there. Not quite, the corpus callosum is intact, as you can see on the sagittal, but you can be caught out by a prominent fornix, which is this area, that stands up and mimics this cavum septum pellucidum. And this is the follow-up scan, and this section's a little low for showing that clearly, and the sagittal section. And this baby actually didn't have a septum pellucidum at birth. Despite arguing whether it did or didn't antenatally, we couldn't make our minds up. You can have partial absence of the corpus callosum. So we've got here something bridging across. We've got something there, but this is quite low to be corpus callosum. And again, and this is actually the hippocampal commissure, which we're seeing more clearly because the corpus callosum isn't there. It makes it more visible. So we've actually got the corpus callosum absent and a prominent hippocampal commissure here, or that's what we thought at the time. And then here, again, we've got what's thought to be the corpus callosum across the top. And have we got a normal septum pellucidum or not? We've got a prominent area, but we've got a normal septum pellucidum. And quite often, if we're not sure on these scans, we will do follow-up imaging. This one shows you the corpus callosum coming across and the septum pellucidum on either side as little leaflets. And this is the follow-up one of the one earlier where we were thinking about agenesis of corpus callosum and a prominent hippocampal commissure or partial agenesis. And postnatally, we've got part of the corpus callosum there, and then we've got a prominent hippocampal commissure below it. So we have got partial agenesis, prominent hippocampal commissure, but the back of the corpus callosum is completely missing. This one had an absent cavum septum pellucidum, so normal corpus callosum, no evidence of a cavum septum pellucidum. And when they're like this, they're fairly easy to pick up, fairly easy to see. Oops. Again, absent cavum septum pellucidum, but corpus callosum. This sometimes mimics what the obstetricians think on ultrasound as a holoprosencephaly because it gives the appearance of a single ventricle. But if the thalami aren't fused and the rest of the structures appear normal, it's just an absent cavum septum pellucidum. You've obviously got to look for associated abnormalities before you can say it's isolated. And you always check your thalami aren't fused and that this isn't a very late holoprosencephaly where you can get two lobes. So you've basically got semi-lobar or lobar holoprosencephaly. Or even something called syntelencephaly, where you just get a tiny bit of tissue fused across the midline higher up. But often those babies also have the fused thalami. So it makes sure that this is definitely an isolated finding. Oops. And then this is just... So things that are associated with absent cavum septum pellucidum is the other end of the severe end of that spectrum from just isolated absence is septo-optic dysplasia. So if you've got an absent septum pellucidum, you should look for associated abnormalities. Septo-optic dysplasias often have cortical migrational defects. They often have schizencephaly. And we've got a closed-lip one at this side and a more obvious open-lipped one on this side and a very irregular, very malformed parenchyma. So when they're as malformed as this, it's easy. When they're subtle abnormalities, it's a lot harder to give a prognostic outcome to them. We'll just finish up with encephaloceles. These are the ones that are quite difficult on ultrasound when you've got this appearance. This is an old machine, but it's a machine that's still in use. We've got the white of the skull, a gap showing a skull defect, and then the white of the skull afterwards. And we've got fluid out in this gap on ultrasound. On MR, we've got what appears to be the skull crossing the gap. We don't appear to have a defect. And this is the same baby, and we couldn't find a defect within the skull at all, but we saw this lesion on the back of the skull. And this makes a huge difference in outcome. These parents had thought about termination if it was an encephalocele. There was no parenchyma out into the defect, and in fact there wasn't a defect here that we could see. So these people continued with the pregnancy, and this is what was thought to be a atretic encephalocele, or an area that's healed and it comes off as a fatty lump after delivery. Oops, sorry. This one's slightly different. This is a much bigger fluid-filled lesion, and as you can see, there is some neural tissue coming out. So MRI is useful to identify the defect and the size of it, but also to identify any neural tissue. We have a small little bit here, and this is actually cerebellar tissue that is coming out through this defect. Supratentorial structures were intact. There's another one. This is the ultrasound, which shows something herniating through the defect. And on the MRI, again, you can see clearly there is tissue out there. Again, it appears to be cerebellar tissue. The occipital lobe, which it was thought to be on ultrasound, is inside the skull, and the skull's intact at that level. So herniation, a little bit of cerebellar tissue, and a massive fluid-filled lesion beyond that. So these will be delivered by caesarean section to protect this, and then operated on after delivery. This is the same one where we've got this the neural tissue herniating out, and it's the amount of neural tissue and the extent of that that the obstetricians are interested to know for prognosis. The neurosurgeons are interested to know for post-op, postnatally, to plan the operation on. But we're also interested in the developing brain within the skull, because with so much CSF into this lesion, the skull isn't developing normally and the rest of the brain is getting squashed. This is that same baby with the neural tissue external to the lesion, to the skull, to the gap, and then this is the CSF in the membrane. And you can see that the postnatal images are very similar. We did this so we could work out the blood supply and what was happening before the surgeons actually took the baby to theatre. This one was referred for assessment to see if there's any neural tissue, and here we can see that there is a lesion, fluid-filled lesion on the back of the head, and there is actually a defect in the skull, but the brain is entirely within the skull and the brain is developing normally. So this has got a defect, but it hasn't got any neural tissue involvement, and then the outcome is much better. The prognosis for this baby was a lot better. This one I think is fairly obvious to everybody, that most of the, or a good half the brain is outside the skull. So this is the skull, that's the defect. So all the brain tissue should be within here. The other thing we can clearly see on this baby is that this skull is very small. Because the brain is outside at the back and the fluid's outside, there isn't the pressure for the skull to develop, and we've got a very flat forehead and a very small skull. And then underlying that, we've got very deformed squashed brain. The anterior aspects of the brain looks normal with the normal ventricles, but we can't assess what's happening posteriorly in this baby. And the outlook for this baby was very poor, although the mum continued, and we did try and repair the skull and get the brain back, but sadly the baby died. Posterior fossa is difficult to see on ultrasound. We've got this problem of vermian growth to keep in mind with MR. So we've got small vermis that gradually plays catch up. So we need to know our normal MRI anatomy and normal anatomy at different gestational ages. This is just showing you the same that we see in post-mortem fetus. So there's still the gap around it. So a larger posterior, the larger amount of CSF space in the posterior fossa, and then gradually the cerebellum grows and fills that space. So the sort of thing we're asked to assess, is this normal or abnormal? How much space is normal? Is the cerebellum developing normally? And it's really useful to have the growth charts from the French book on those. This baby clearly has a problem because it's got ventriculomegaly, it's got a small cerebellar vermis, and it's also got a kinked brainstem. I don't know if you can see that, but it comes down and wobbles back in two. So that baby's got a genetic defect. It's got Walker-Warburg syndrome, and it's just classically a small cerebellar vermis and a kinked brainstem and the ventriculomegaly. They all fit together, and that's autosomal recessive, I think. Whereas this baby is normal for this gestational age, so this is what we should be seeing. We can get posterior fossa cysts, which cause this appearance of increased fluid space and push the brain forward. And the outlook for these is a lot better because this is displacement of the brain rather than destruction. But obviously, you need to keep an eye on this. If it gets too big, it can start to cause developmental problems with the rest of the brain. This baby was sent with a small cerebellum on an ultrasound, and the cerebellar vermis looks to be normal on the midline section. But when we actually look at the coronal and the axial, we've got one smooth appearance here. There's no attempt to form two cerebellar hemispheres. So we should have much more of a dumbbell-shaped structure here. So come out at one side, go in again, come out again. And this hasn't. And this is a malformation called rhomboencephalosynapsis, which gives an overall small cerebellum and classically doesn't split into two halves. It's a fused cerebellar hemispheres with no vermis. And this is just another picture of the same thing. So small cerebellum, look to see if the structure is normal or if it's just overall small, or is it structurally malformed, as in this case. So just look at echo pore areas. This was seen on ultrasound. It didn't have flow in it on ultrasound because the flow was so low, but this is actually blood seen on MR, which has caused the brain to be displaced forward, but the underlying brain is normal. And this is a dural sinus fistula, where we're getting flow of blood in here, but low volume flow. Some of these appear to resolve during pregnancy, or at least get smaller, and some of them have disappeared completely. Others have a poor prognostic outcome. But the more that patients that are continuing with these abnormalities, the more we're seeing these resolve. And we can follow them up on MR and ultrasound, watch them get smaller. Some of them continue to get smaller postnatally. So the prognosis that we used to give is changing depending on what we're seeing antenatally now. So these are having a much better outlook given to them than we initially did 10, 15 years ago. Other things we can see are infarcts, where we've got destruction of the brain parenchyma, so you've lost your symmetry, you've got abnormal areas here where you've got what look like little bits of brain, lots of fluid, and this fitted with a cerebral infarct, postnatal images, post-mortem images, and then post-mortem confirm that. Other areas which may look the same as that previous case of an infarct are like this on ultrasound, which appear as a hole. But when we see it on MR, it's got a well-defined margin. So this is an event that's occurred very early in gestation. So it's not an infarct later in gestation, but might have been an infarct in the first few weeks of the pregnancy. And what's happened here is it's corticated normally. So this was picked up late in pregnancy, not seen initially. The family continued with the pregnancy, and the baby's 6 months old and doing really well. And it's this parenchymal outline we can see. So the cortical margin is complete, which indicates that it's happened early in pregnancy. And those appear to have a better outlook than the ones that occur late in pregnancy, where it's much more of an infarct and much more significant on the prognostic outcome. Back to the hydranencephaly. Another severe ventricular, the hydranencephaly again with just this margin of tissue at the front and the back. And then what's the value beyond the prognosis? This couple knew the prognosis was poor. There was an abnormal corpus callosum, agenesis of the corpus callosum, but there was asymmetry as well. But the asymmetry was just in this area. So this couple chose to terminate. The value of the MRI here was to help the pathologist select the area to actually get the histological diagnosis from. So rather than just slice blindly, the pathologist was led by the antenatal MRI images and was able to get that area of tissue and get a histological diagnosis for the couple. And this is the pathology slices. And similarly for this case, we've seen this earlier on in the talk, where this side is normal and this side is underdeveloped, and we're able to help guide the pathologist. We'll just flick through those. Pathology. What I would say, we've concentrated on the brain, and that's fine, and I think, you know, CNS is probably the part that most people are asking for at the moment, but even when you're doing the CNS and you're concentrating on that area, it's probably well worth looking beyond the brain. And these are just a few examples to finish on. This is a baby who was sent through because they could see the brain very clearly, but when we look, there's hardly any skull around it. So the abnormality here is the lack of the skull, and this baby had osteogenesis imperfecta. It's also got ascites and pleural effusion. So we knew this baby was very sick, but mum wanted to continue with the pregnancy, and we wanted to get as much information as possible for her. This baby was sent with something not quite right in the brain, and the brain on MR looks absolutely fine, but the skull shape's a little odd. It's too big frontally, and it's quite wide and squared off here. And this is the follow-up, where on ultrasound it was really difficult to delineate any normal anatomy in the brain of the baby, whereas MR, the brain is actually normally formed. It's an odd shape, but it's a normal structure underneath that. And the problem is the overlying skull. And this is a baby with Pfiffer syndrome. This baby had a thoracic diastematomyelia, but also had an absent neck. So although the brain and spine were fine, the foramen magnum is very big and there is no cervical spine to this baby. This is just another view of this baby, showing you that the heart is actually at the level of the thoracic apices, which is at the level of the neck, which isn't there. And then the humeral heads are almost at the level of the inner ear in this baby. So everything is squashed together because the baby hasn't got a cervical spine. Finally, this was sent with a single kidney. So we've got a single kidney in this baby. We've also got a small diaphragmatic hernia in this baby. We've also got a short spine that ends abruptly, so the spinal canal is fine, but the spinal cord ends abruptly. And we've got a very flat midbrain, so we've no obvious pons there. So we've got significant abnormalities in this baby. And then on the T1 sequence, we added dilated bowel to it as well. And then it's just to look at the whole baby, a bit like the osteogenesis imperfecta baby. This baby has got something that's not quite right around the muscles. And when we looked back to our original images of other gestational age babies, we should have dark muscles and lighter bones. And here we've got dark bones and very little muscle. So this baby's problem was a muscular abnormality rather than any other system abnormality. And the T1 will show you the bright muscles which confirm this. Neck lesions sometimes come through. And here we've got a lesion in the neck, which looks like this is a mass in the neck, but the airway is patent, as we can see by this white fluid-filled line down there. It's a patent airway. When I did the T1 images, we get this appearance, and this is a fetal goiter. Whilst other neck lesions we have clearly cause airway compression, and this is a huge mass lesion compressing the airways that had to be delivered by an exit procedure, and this is a teratoma. Finally, just think about aids for interpretation. We've got the textbooks and biometry. So these are the two textbooks. The Catherine Garel, the French one, gives you all the normal development and biometry that you'll need, and that's supplemented by papers for earlier gestational ages, because Catherine's book starts at 22 weeks. And then the Daniela Preyer book will give you lots of examples of pathology, pathological follow-up, different examples in different fetal systems. So both of these are really good bench books if you're going to start doing this as a service. And so papers are coming out all the time with new biometry, new data. Just check them carefully and interpret them with care. And to be honest, these are probably the better things to rely on, the two bench books that are established throughout the world now. So reports for clinical practice, you need to know the gestational age, you need to know the body area image, you need to have some idea of syndromes. It's really useful to tell the obstetrician what you have told the parents if you talk to the parents, and any access to follow up, and then have a really good MDT. So if you're doing this work, don't do it in isolation. Work with have an MDT set up. Work with everybody who's going to look after the mum or look after the baby following delivery. So there's the normals, which are you really need to know your normals. You need to know your gestational age, because this would be normal for around 22 weeks. But this is actually 26 weeks. And finally, we'll finish, finish up with a poll question. Do we allow obstetricians to develop this fetal MRI service, or do we keep it to radiologists? Right, okay, keep it to radiologists. I think I agree with you. I think we have to keep it to radiologists. I think if we give it over to obstetricians, we're going to lose the radiological skills that are needed to interpret from first principles. And a lot of the work I still do is based on first principle interpretation. However, if you've got a really skilled obstetrician who's willing to learn the physics of MR and the basics of MR, and has an obstetric background for looking at using ultrasound to image the fetus, they may be able to provide a really good quality service. And maybe we should work together, obstetrics and radiologists, to develop this service. So hopefully it's been a bit of a whistle-top tour, but hopefully it's been useful to you. I'm quite happy to take questions by email. I'm quite happy to take questions on the chat now. And hopefully we'll be able to go on and do some other areas of the fetus in webinars later on. So thank you.